first, I would like to thank the organizing committee, Professor Risham Awad, Professor Nihar Ragel, Professor Safa, Dr. Professor Rania for organization of this exciting conference, and as we did enjoy the first session, the second session shows it will be more exciting. And it's my pleasure to introduce Professor Yasser Elsayed. He is the associate professor of University of Manitoba and director of Integrated Hemodynamic Program and the chair of International POCUS New. We did enjoy his morning lecture, and welcome to the warm Egypt.
Yeah. Thank you very much. Yeah, thank you, Professor Reda, for the kind introduction. And it's my pleasure to be with you again. I will try as much as I can to speak slower and at the same time to be strict with the time. I think we're running out of time, which is really a challenge. So I will probably skip some of the slides. So I will be speaking in this presentation about management of pulmonary hypertension. I have nothing to disclose in this presentation. And I have three main objectives to discuss over the next 30 minutes. At the end of this presentation, you will be able to, hopefully, demonstrate the physiology of pulmonary hypertension, demonstrate the 5 main phenotypes of pulmonary hypertension. So we will discuss in this presentation that not all of the cases of pulmonary hypertension are the same. There are phenotypes, and some of them you need to even avoid to give pulmonary vasodilators or to limit use of oxygen. And then demonstrate the therapeutic options and the intervention algorithm at the end. So management of pulmonary hypertension, I have divided the presentation into 5 sections. To make it easy and increase knowledge retention, I will discuss the basic physiology, then physiology of the clinical phenotypes, and then how to diagnose pulmonary hypertension, therapeutic options of pulmonary hypertension, because they are not the same, the phenotypes are not the same, so we cannot treat all of them the same way, and then management algorithm. First, about the physiology. So pulmonary artery pressure, that's a very important slide to understand the physiology of pulmonary artery pressure. So the pressure, either pulmonary or systemic, it is the equation which pressure, the pulmonary artery pressure, directly proportional to 2 things, pulmonary vascular resistance and pulmonary blood flow. So any change of any one of them will change the pulmonary artery pressure. It is not the same as some of us might imagine that it is the pulmonary vascular resistance, higher pressure. No, it is either the resistance or the flow. So, and the resistance is 2 types, either arteriolar, which is the reactive and the reversible vasoconstriction of the smooth muscle or muscular layer of the arterioles, and it's typically baby chain pulmonary hypertension. And this muscle layer is very sensitive to high oxygen. If the infant did not get enough oxygen after birth or during postnatal transition or during delivery, will develop pulmonary hypertension because the fetal pulmonary vascular resistance is very high, and this transition to lower resistance after birth should be induced by oxygen. And then we may have irreversible. So not all of the arteriolar vasoconstriction is reversible, can be irreversible in hypoplasia of the vascular bed. This is expected pulmonary hypoplasia and the congenital diaphragmatic hernia, which is the topic for afternoon today. And then pulmonary vascular resistance can be venous or venular, with the pulmonary venous hypertension is the most tough part even for the best cardiologist to treat and diagnose to begin with pulmonary venous hypertension, because it might need to be diagnosed by cardiac cath, not by echocardiography. And in this situation, you will see LV dysfunction, left ventricle dysfunction, pulmonary venous stenosis. And LV dysfunction, I will describe, is very important to diagnosis, because if you give pulmonary vasodilator, regardless the type, sildenafil or nitric oxide, you will worsen the LV dysfunction and circulation. So we need to understand that very well. And then pulmonary blood flow, you may have high pulmonary blood flow in case of PDA or AV malformation, so high circulation through the right ventricle, or low pulmonary blood flow, Typically, we are not using pulmonary hypotension in our practice because the pulmonary artery pressure is physiologically low. That's why we have more cases of pulmonary hypertension, but we may have low pulmonary artery pressure. We are not using pulmonary hypotension, but typically when we have systemic hypoperfusion, like in shock, or right ventricle hypoplasia or severe RV dysfunction, you may have very low flow through the lung. In this situation, it is also contraindicated to give any pulmonary vasodilator because you will lower the flow even more. So it is really tough and not easy to diagnose the phenotypes of pulmonary hypertension. Let us discuss that in details. So pulmonary hypertension occurs with increased pulmonary blood flow. So that's a question for you. So try to answer this question first before we carry on. So the pulmonary hypertension occurs with increased pulmonary blood flow or increased pulmonary vascular resistance. You need to select one. Or increased pulmonary venous pressure, or all of the above. So I think makes sense now, it is all of the above. So it can be anything. It can be increased flow, can be increased vascular resistance, arterial vascular resistance, or it can be increased venous pressure. And you may have overlap, you may have more than one at the same time, so make it even difficult, more difficult. Clinical phenotypes, that's the most important part of the presentation, the clinical phenotypes, how to differentiate between them, and how to design or to modify the management based on the clinical phenotypes. So first, the normal cardiopulmonary interaction. So we have the lung, and as I mentioned during the first presentation, ventilation perfusion matching should be close to 1, or typically 0.8. So the amount of air should be almost equal to the blood flow. So the ventilation is equal to perfusion. The cardiac output should be equal to minute ventilation. So, and we have the heart with minimal left-right shunt through the beta-inframun ovale, which is physiologic. And we have dominant right ventricle, so the apex made by left ventricle, just beyond the postnatal transition. Normal biventricular performance, as you can see, and you can see also normal systemic blood flow, and normal heart performance, as you can see in the echo. The top image here is for a chamber view with good filling, good contraction, and short axis parasternal view with the septum. The interventricular septum is rounded and the left ventricle is rounded. It means that the right ventricle pressure is less because the septum is surrounding the left ventricle with higher pressure. And the right ventricle is like a crescent. So that's a normal relation, normal ratio between the right and left side pressures. So let us now discuss one by one the phenotypes. And the first one is the high pulmonary vascular resistance, or typical PVHN. So not all of pulmonary hypertension PVHN. Don't use PVHN as the same synonym for pulmonary hypertension. They are different. Pulmonary hypertension is a spectrum of diseases, and the PVHN is one of them, the first one. So we have high pulmonary resistance, and they have more ventilation and less blood because of the blood restricted by the high resistance. You have dominant right ventricle, so the apex made by right ventricle, and you have right to left shunt instead of left to right through the beta-inframun ovale or PDA, and dominant right ventricle, as I mentioned, and normal biventricular performance. In this phenotype, you have normal performance, although the right ventricle is with a strain due to the high resistance, normal systemic blood flow. There is no hypotension. The common scenario here, just a common scenario, we can consider term or preterm infant with hypoxemic respiratory failure, secondary to lung disease, or due to perinatal asphyxia or hypoxia. So perinatal hypoxia did not get enough oxygen, or secondary to lung disease. Now you can see the echo is different from the previous one. So you have the right ventricle is dominant with tricuspid regurg, and the right ventricle is bigger than the left, pushing the septum from right to left. And here we have the short axis now is not rounded anymore. It is even posed from right to left because the right pressure is higher than the left. And the left now during systole is more crescent because now the ratio is reversed. The right higher than the left. And then the PDA, you have the pulmonary artery and the three branches, left pulmonary, right pulmonary, left pulmonary, and the PDA is right to left. And because the color is below, as you can see. So management in this case, optimize ventilation, target saturation usually 90 to 95, and pulmonary vasodilator might be needed either with the sildenafil or nitric oxide if you have it. And caution with preterm infant, use pulmonary vasodilator very cautiously, because a PDA might reverse the shunt in no time. So use like whatever pulmonary vasodilator you have, and then follow up by echo shortly after that, because the PDA might reverse in few hours. In this situation, you might get worsening of the pulmonary hypertension instead of improving. Second phenotype. Second phenotype is also the second common one, when you have high pulmonary vascular resistance and now the RV is tired because of the high strain, and it is now presented with dysfunction. So you have dysfunctional right ventricle, and a small left ventricle compressed, ventilation perfusion mismatch still, more ventilation, there is no issue with the ventilation, and the blood flow is decreased, so the ratio is more than 1. So you have normal ventilation, but perfusion decreased because of decreased blood flow, dominant right ventricle, and right to left shunt through the PDA, and poor ventricular performance. As you can see here in this example, very poor contractility of the right ventricle, and also in short axis view, the heart is purely contracting, hardly squeezing the blood out. The systemic blood flow usually is normal in this case. Management option, optimize ventilation. Again, that's a priority for any kind of pulmonary hypertension. Target saturation 90 to 95. Pulmonary vasodilator, nitric oxide or sildenafil can be considered. And then we need to improve the RV performance. So you need to use a medication to improve that, which is merinone. If you don't have merinone, you can use dobutamine. Merinone is inotropic and at the same time lusitropic. So improve the compliance of the right ventricle, and improve the systolic performance at the same time. At the end, prostaglandin in the refractory cases. So if the RV dysfunction is really bad and you cannot get the pulmonary hypertension improved, you can open the ductus if it is closed by prostaglandin in this case. And then the common scenario here, The common scenario, term or preterm infant, the same with hypoxemic respiratory failure or prenatal asphyxia. It's typically the same like the first phenotype, but with more severe advanced stage. Then the third phenotype, the most tricky and the most, if you cannot diagnose this case, it means death. It means the infant might be lost in no time. It is LV dysfunction or pulmonary venous hypertension. So you have the more blood flow through the lung because of high left atrial pressure, and because you have in this case LV dysfunction. So the left ventricle cannot eject the blood out, so the blood will accumulate, will reflect to the left atrium, more venous pressure, and this venous pressure will make the lung congested with blood, so the ventilation perfusion ratio will be less than 1. Dominant right ventricle, in this case, poor LV performance and hypotension or low systemic blood flow. The common scenario here, term or preterm infant with hypoxemia secondary to failure of postnatal transition. Postnatal transition in preterm infants sometimes is really tough because the left ventricle is facing high resistance. So not all of the preterm infants can accommodate for the increased resistance after birth. In this situation here, you have LV dysfunction, and I have one of the examples in infant with AV malformation. AV malformation might be presented with very high right side flow and LV dysfunction and more congestion of the left side, and the pulmonary venous return is very high. In this situation, we should not use pulmonary vasodilator as the first line, and we should not use it until we get the LV performance improved. It is contraindicated to use nitric oxide, and the infant might die from systemic hypotension. You may have PDA right to left in this case, and the PDA will be shifting blood from the pulmonary circulation to the decreased systemic circulation. So it is similar to coarctation physiology, when you need to maintain the PDA right-left shunt in this case. Otherwise, if you reverse the shunt left-right, you will worsen the systemic circulation more, and the infant will get more hypotensive and may die from shock. So never use pulmonary vasodilator in this phenotype. Next phenotype is a biventricular performance, even worse. So you have both ventricles are not really contracting well. As you can see here, the heart is purely contracting. In this echo view for chamber view, the heart is very poorly contracting at this stage of shock. And this one with the tachycardia, and this infant here with bradycardia, but they are the same, very poor biventricular performance. You have the PDA shunt may be variable according to which one is lower, the systemic or pulmonary. So it can be variable, low systemic circulation. So low systemic circulation, hypotension at the same time is very difficult to manage this case. And optimized ventilation is a priority. We accept wider target saturation 85 to 95, Merinon dobutamine or with norepinephrine, because you may need to control the heart performance, and also because of the systemic hypotension, you need vasopressor like norepinephrine. So we use usually combination of Merinon and norepinephrine in this case. Prostaglandin might be considered in refractory cases to open the duct. And the duct in this case can, as I mentioned, can be left to right or right to left according to which circulation is affected more, either the right side or the left side. Steroids also might help in this scenario. It's a common scenario in preterm infant or term with the hypoxemia secondary to severe hypoxemic respiratory failure, severe, with failure or failure to postnatal transition. Without echo, you cannot diagnose this case. The transient RV hypertrophy, that's number 5 with the least common. So I moved from the phenotype number 1, 2, 3 to the least common one, and really difficult to also manage transient RV hypertrophy with low pulmonary blood flow. This scenario is common if the infant underwent antenatal closure of the PDA. So the infant might die in utero or might born with very significant or severe RV hypertrophy because of the PDA will relieve the pressure from the right ventricle. If the PDA closed prematurely, for example, simply if the mother used an nonsteroidal anti-inflammatory before delivery, the PDA might close and you may have RV hypertrophy. In this situation, you have ventilation perfusion mismatch of more than 1 because of very low pulmonary blood flow through the right ventricle. Right ventricle cavity is very small, very hypertrophic, dominant right ventricle, impaired RV, diastolic performance, borderline systemic blood flow, or hypotension. What you need to do in this case to save this patient, as you can see here in the forward chamber view, the RV is very hypertrophic. LV is okay, but RV is very hypertrophic. Almost there's no space left for blood. Management, optimized ventilation, target saturation more than 75. Treat this case as congenital cyanotic heart disease. Don't give oxygen, because oxygen might lower the pulmonary blood flow, resistance more, which might lower the blood flow through the circulation. And don't give any troops in hypertrophic heart. That might actually worsen the situation. Infant might die if you give too much in troops, because the infant will rely on filling and the troops will decrease the filling, especially if you use troops that might increase the heart rate. Prostaglandin might be used in refractory cases, and no nitric oxide to be used, or no pulmonary vasodilators to be used in this case. And this needs for sure echocardiography for diagnosis. So we have all of the phenotypes all together. The first one, high pulmonary vascular resistance. Second one, high pulmonary vascular resistance with RV dysfunction. Third, LV dysfunction, which is, as I mentioned, don't give pulmonary vasodilators. You need to improve the LV performance by Merinon. Biventricular dysfunction with systemic hypotension. Also, you need to improve the performance by giving Merinon or dobutamine together with norepinephrine. And then the last type, transient RV hypertrophy. Don't use too much medication, just accept saturation greater than 75. And typically, as I mentioned, we are using near-field spectroscopy to be sure that the brain is getting enough oxygen, even with the low arterial oxygen saturation. You may need to use a prostaglandin in this case, but don't use any troops, don't use any pulmonary vasodilators. These are the phenotypes. To my knowledge, so far, I don't have other common phenotypes. The last one, you may see that case, the last phenotype, maybe once a year. But the first one, you may see it almost in weekly basis. So how to diagnose pulmonary hypertension? Clinical suspicion is important. Echo confirmation and CT angio or cardiac cath or MRI might be needed in some situations. So clinical should not be used alone. In clinical evidence, pulmonary hypertension, there is 2 things. Differential oxygenation pre-ductal and post-ductal, and differential oxygenation more than 5 difference is significant, but there is a limitation of that, because you may have infant without PDA, then you may not have the difference, although the pulmonary hypertension might be high. Or if you have more than 2 desaturations within 12 hours period, unexplained in term infant. That's normal in preterm infant, but if you have term infant who is more than 2 desaturations within 12 hours, you need to apply the pulse oximetry screening and to get an echo done. Or if the infant failed pulse oximetry screening upon discharge. There is the published Canadian Pediatric Society position statement on pulmonary hypertension. And in this statement, we described most of the phenotypes, and we described also algorithm and how to use cautiously the oxygenation or the pulmonary vasodilators without considering all of the pulmonary hypertension just for one phenotype. So this is very helpful. I encourage you to read it in details. So it is exactly similar to the Canadian Pediatric Society statement, position of pulmonary hypertension, written in published as an article in Journal of Neonatology. And in this algorithm, typically when you have pre-ductal saturation less than 85, you have to check if there is any parenchymal lung disease. If the answer is no, you have to check if there is pre and post saturation gradient. And you have 3 types of gradients, either right arm equal to the lower limb. It could be with the closed PDA, or it could be with RV dysfunction as well. It could be really severe. So don't consider that pre and post saturation difference is really very reliable. It's reliable in limited situations. If you have the right arm more than the lower arm, it could be pulmonary hypertension, or it could be coarctation of aorta. So you need to diagnose that by confirm that by echocardiography. If you have the opposite, the right arm less than the lower limb, you need urgent echocardiography, because it could be a transposition of great arteries with pulmonary hypertension. It's even more difficult to manage without echocardiography. So targeted neonatal echocardiography, it is a standard of care in Canada for most of the units for almost 10 years. So the neonatologist, he is a person who is doing the hemodynamic study or echo for one of these indications. So targeted neonatal echocardiography is a pulmonary hypertension or PDA assessment or shock. It is for the neonatologist, congenital heart disease for pediatric cardiologist. So targeted neonatal echo criteria for pulmonary hypertension, you have 2 criteria. Either pulmonary hypertension is normal RV performance. You have at least 2. You should not rely on one marker, either tricuspid jet more than 2/3 systemic circulation, or if you have IV flattening or pose from right to left, PDA bidirectional or left or right to left, or dilated right ventricle more than the left. These are the parameters. We have much more, but these are the basic parameters. Or pulmonary hypertension with LV dysfunction that can be diagnosed easily by echo, by like there is a parameter called the tricuspid annular systolic excursion. If it is low, it means there is RV dysfunction, or also evaluate the RV output by echocardiography. If you have less than 150 ml per kg per minute RV output, right ventricle output, that could be considered a marker of RV dysfunction. And classification of pulmonary hypertension, mild if the pulmonary artery pressure is 2/3 systemic, moderate if close to or equal to systemic, severe if you have suprasystemic pulmonary artery pressure, or any kind of pulmonary artery pressure with RV dysfunction. Tricuspid regurg is important. I may just skip some slides for the sake of time. And this is echo triage in our unit. So for any infant with PDA hypotension unresponsive to low dose of vasopressors, so for any neonatologist using vasopressor or any troops more than 10 mics per kg, and there is no improvement, that's indication to consult the hemodynamics trained neonatologist to do echocardiography and assess the hemodynamics overall and prescribe physiologic-based medication. For the pediatric cardiologist, any congenital heart disease, arrhythmia, or cardiomyopathy should be managed by the pediatric cardiologist. And that's an algorithm which is available in most of the units in Canada. And that should be differentiated from another type of ultrasound, which is point-of-care ultrasound. So there's just recently released guidelines, as like there's 2 reports, technical report and the clinical report, in guidance for the clinical in rendering pediatric care on using point-of-care ultrasound at the bedside. In this guidelines, which we have been really working on it for almost 4 years, which is almost like the average time to finish any American Academy of Pediatrics guidelines. The point-of-care ultrasound just screening is different from a hemodynamics study. So when you use point-of-care ultrasound, if the infant is crashing or crashed or very unstable, any neonatologist trained of point-of-care can do a screening and immediately should refer the case to the pediatric cardiologist or the expert in hemodynamics. So that's not the same level as detailed echocardiography by the teen echo. And we designed in these guidelines almost parallel, similar algorithm, similar to the the NRP program, neonatal resuscitation program. So if the infant is not responding to resuscitation, when we don't know what's going on, we can apply this algorithm. And the same ways as NRP, start by lung assessment, heart assessment, and then end organ, other organ assessment for any bleeding like abdomen and the brain. So it is a step by step, and each organ you need to exclude 3 or 4 certain diseases, like in lung, consolidation, lung collapse, or pneumothorax, or presence of pneumonia. If there is a heart issue, you need to rule out pericardial effusion, weak contractility, or pulmonary hypertension, and so on. So it is available on, online for free access. Anyone can download it and read it in details. Oxygen, pulmonary vasodilators, you need to just use a physiologic prescription. And pulmonary hypertension with high pulmonary vascular resistance, you need to use a target saturation 90 to 95 if this pulmonary vascular resistance related to pulmonary hypertension, and the brain saturation between 60 to 80. Pulmonary hypertension secondary to high pulmonary blood flow, like in left-right shunt, or pulmonary venous hypertension, you need to use the lower target saturation 85 to 90 because you need to limit the flow through the lung. For example, in case of pulmonary venous hypertension, LV dysfunction, or in case of arteriovenous malformation. Pulmonary vasodilators indicated in documented pulmonary hypertension by echo, unresponsive to optimization of ventilation, which is a priority. Presence of significant hypoxemia requiring FiO2 more than 50%, and moderate to severe illness as defined by oxygenation index more than 25. Pulmonary hypertension due to failure of postnatal transition. Positive response to trial of pulmonary vasodilator. If you try it and the oxygenation is better, it means that you are in the right direction. Contraindication, which is more important compared to the previous slide, because like the first, don't do harm as a priority compared to like you help or apply the right intervention. So known or suspected total anomalous pulmonary venous drainage, you should not use any pulmonary vasodilator. Congenital heart defects or congenital conditions that would worsen with a result of increased pulmonary blood flow, like in coarctation or hypoplastic left heart. Left ventricular dysfunction, as I mentioned, during one of the phenotypes, pulmonary venous hypertension. So these are the 4 common contraindication of pulmonary vasodilators, either nitric oxide or whatever, sildenafil, any type of pulmonary vasodilators. Don't use in any one of these diseases because typically the pulmonary circulation would worsen. And cardiovascular support, I will discuss that in details during the next session. So we have vasopressors, inotropes together with vasopressor, or inotropes as a vasodilator, and fluids, steroids. So vasopressors, pulmonary hypertension with systemic hypotension. If you have pulmonary hypertension together with systemic hypotension, you can use vasopressin or norepinephrine. Inotropes and vasopressor, pulmonary congestion with systemic hypotension. And why I selected dopamine, that we are using one of the side effects of dopamine, which is increasing pulmonary vascular resistance. Dopamine is a medication that like much less used in our unit because it might significantly increase pulmonary vascular resistance, but I can use this side effect if I have a case of pulmonary hypertension. It's the same like epinephrine. Inotrope with the vasodilator like dobutamine or merinone indicated when you have ventricular dysfunction, as we described. And fluids as a medication should be used only with hypovolemic shock, not just as a candy to be given for everyone as a gift. So it should be used cautiously with only evidence of hypovolemic shock, not for everyone. And then in the refractory cases, you can consider using steroids. And I will discuss the details. If you would like to read more details about hypoxemic respiratory failure, just like that's not really promotion for the book, but there's a book that includes everything you need to know hypoxemic respiratory failure. And we started to understand more about pulmonary hypertension when we established our hemodynamics research lab. So there's not a neonate, that's a piglet in the animal lab. And we have like a setup of animal lab almost similar to intensive care, and like a teamwork of anesthesiologist and my colleague, Dr. Shamla Dakshina Marti. And we cross-appointed with the Department of Physiology. So we do that as a physiologic research lab, and we published the use of vasopressin in pulmonary hypertension in our lab, and also the validated lung ultrasound and megalith model also in our lab for the first time. So yeah, I need to maybe yeah, so that's the last slide. If you have infant with hypoxemia, infant with hypoxemia, optimize ventilation and lung recruitment, rule out pneumothorax, and then consider echo. If there is acute pulmonary hypertension, confirm it, use a pulmonary vasodilator. And if there is no good response, you have two options. Either it is due to low systemic arterial pressure, like hypotension. If the answer is yes, with RV dysfunction, consider dobutamine, epinephrine, or prostaglandin in unresponsive cases. If there is RV performance is normal, then use vasopressin or norepinephrine and hydrocortisone in unresponsive cases. But if the answer is no, there is no systemic arterial pressure low, no hypotension, you can use Marinol or dobutamine. So keep in mind when you use Marinol or dobutamine, the systemic blood pressure should be normal first. So you need to get the blood pressure normalized before using Marinol because it's a vasodilator drug. And the same for dobutamine. And when you use Marinol, don't combine with dobutamine, and that will be too much vasodilation. So don't combine both together. And then don't use pulmonary vasodilator in presence of LV dysfunction. I repeat that again and again. So to conclude my presentation, as I started with three objectives, I have three conclusions. Pulmonary hypertension is a spectrum of multiple phenotypes, and not all of them treated as the same way. Management is based on the underlying physiology for each phenotype. And pulmonary hypertension is better to be managed by a trained neonatologist in hemodynamics. And we have like significant success in more physiologic implementation and less time to clinical recovery, much less time on medications, much less time on pulmonary vasodilators. When you have the neonatologist at the bedside, he understands the neonatal physiology very well, and he's the one responsible to write the prescription and apply the management plan. Thank you very much. Yeah, so we'll just carry on with the next presentation.
It's my pleasure الحقيقة إن أنا أكون موجودة النهاردة. نشكر طبعا دكتور ياسر، المحاضرة جميلة جدا يعني، والتقسيمة pulmonary hypertension يعني من الحاجات اللي بتبقى عاملين لنا مشكلة. نقدم حضرتك بقى logical selection of cardiovascular support، برضو من الحاجات